So, Haley, you work in the NICU. What is that?
The NICU is one of those places that I think everyone has maybe heard of, but a lot of people don't always expect that they're going to get to know what it is. And it's the Neonatal ICU. Neonates being brand new babies within a month.
Brand new newborns.
Yep, absolutely.
Up to a month. Okay.
That's the definition of it. So we will see babies that are just born and they need our help. So once a baby goes home, we don't typically see them come back.
Okay, good, because that was another one of my questions. You have a lot of babies that come back maybe a week in and all of a sudden they start crumping a little bit at home and mom gets worried. And...
Yeah, it absolutely happens all the time. I mean, babies go home, they need to come back. But that's the big difference between neonatal and pediatric. So pediatric, these kids are a little older, they've gone out, they've had exposure to outside germs, whatever. They come back, they usually have to go see the peds people. But in our case, our babies are born, they stay in the hospital, they stay with us. So in a sense, like our unit is very clean. We don't have any patients who've been outside of the hospital walls, keeping it real safe, especially for those really itty bitty ones.
Hey, honestly, I don't know if I've ever been in a neonatal ICU. Are they up in those little containers that look like they're an Avatar or something? You know what I'm talking about?
They're pods.
Yeah, they're pods. Are they actually up in those, or is that just reserved for the really sick ones? Or
yeah, those are incubators or isolates. You may hear them referred to as either, and they're basically just little temperature boxes. Some of them have humidity control, which is pretty cool. So when these babies come out and they're super tiny, a lot of times they can't maintain their temperature. So we put them in those boxes. They're pods, they're Tupperwares. And it helps them maintain their temp until they're big enough to do it on their own. It's a big day for a baby when we can graduate them to a big boy crib.
Do they have the gloves that you could put on and touch the baby?
Like Ebola style?
You know what I'm saying? Like gloves that touch. I mean, you have to do stuff to the baby, right?
Yeah,
Can
so
you
there's
open it up
these little pod door things on the outside, little circles that kind of open up, and you can reach in there. Yep. No, but there's no gloves attached.
Have you ever seen The Simpsons where Homer Simpson's going and like messing with the plutonium or whatever it is?
Yeah, luckily our babies aren't radioactive, so we don't have to go that far.
Okay, well, how soon after they're born? So say the APGAR is really poor. Is there a certain level of APGAR that they automatically go to the neonatal ICU, or is it kind of like clinical judgment, like doctor determines they need to go to the neonatal ICU?
So actually, I attend deliveries at our hospital where we have high-risk pregnancies, high-risk deliveries. The NICU team will attend any delivery, consider it to be high risk, or once a baby comes out and isn't high risk but starts to show signs of needing some extra support, they'll page us and the NICU team comes in and we assess, we evaluate. In some cases, the doctor is or isn't with us, and we have to make that determination based on that particular baby. It's never cut and dry. It's always just, how does this particular kid look? What are their circumstances? And then we go from there. And we can get them up to our unit within just a couple minutes of being born.
How often are they high-risk babies?
Considering our unit is a high-risk labor and delivery unit, we get a pretty good number of them. And you'll see things anywhere from prematurity to congenital defects to genetic disorders, problems with mom that could potentially affect baby's outcome.
Drug use, stuff like that?
Absolutely. Anything mom is doing that could affect the baby and have a negative outcome for them, we step in and make sure that that is handled.
It's such a weird world, honestly. When I go up to the, in the middle of the night, I get called in for these crash C-sections, right? These moms wake up, they were just under general anesthesia, and they're like, where's my baby? Like, what the fuck just happened? I bring them upstairs, and they meet their little baby, and it's like, I don't want to leave. I'm like, it'll be 3 a.m, and sometimes I just want to stay and hang out, because I'm like, this is like such an endearing moment. And so I'm sure you get a lot of those once the babies start to recover, and graduate into the big boy crib, or are ready to go home. That's got to feel amazing. The first time that happened, how did you feel?
So my job is full of so many amazing moments, and I have to pinch myself a lot because it's just incredible to be a part of these huge moments for these people's lives.
I don't think I could handle it. I think, and that's one of the things about the ER is like we see them, we get them good enough to go to the ICU. They're never like, if they're in critical condition, we get them stable enough, they're going to the ICU, I'm never going to see them again. I couldn't handle it. I'm one of those people that like, I'll see a commercial that's really touching and like, start tearing up a little bit.
You have these moms after a week of a painful recovery for them, a painful first week for the baby, and after a week they get to sit in a chair and they get to hold their baby skin to skin for the first time, and they have tears in their eyes, and it's just, you stand there and it doesn't matter how many years you've been at it, it'll get you every time. Just those moments make every bit of it worth it.
I loved it. I was always drawn to it, and I was thinking, it's one of those things where as a dude you think, they're not gonna want me. me. I would suspect that would be different in NICU versus labor and delivery.
It's a lot less personal in the mom. I mean, you help with breastfeeding. That's probably about as far as we go, as far as dealing with the mom. It's all about the baby. The baby's my patient. We're the epitome of family-centered care because we've got this baby whose parents are so involved. But the baby is my focus, the baby is my medical concern. I think for men, we have a number of them in the NICU. It's incredibly rewarding for both the women and the men that work there. I think the moms are extra appreciative when they see a really sweet male nurse come in and take care of their baby, and it's rewarding all around. It's really cool.
What's the most common complication in the NICU for babies?
Well, hands down, prematurity.
Prematurity.
Majority of the patients we see are there because they're just born too early. So they can be the size of my hand. They could be just a couple weeks before their due date.
The size of your hand?
Yeah, we've had babies that are literally just a few hundred grams and little teacup pocket babies. And
they make it.
They do. Science is amazing. I'm constantly blown
I mean,
away.
that blows me away right there. I mean, I've seen a couple births, and those babies come out not the size of a hand. They come out like they should be walking at this point. Second to prematurity, what would it be?
Respiratory distress. You got a lot of these kids that come out that they have fluid in their lungs that just hasn't. Usually that gets squeezed out during the birth process.
Fluid, is it like meconium or is it like...
It's the amniotic fluid. When you're inside the tummy, your lungs are filled with fluid. When you get pushed out the birth canal, it squeezes out the fluid and you scream, pops open your lungs, and you should be good. Sometimes that process doesn't happen. Sometimes when you're born C-section or you're in that birth canal for too long or something happens and your lungs just don't quite clear. So we'll get a lot of those kids even at their due date who come out and they just need a little help breathing. They need a little pop of the lungs to get them going.
Sometimes little kids come into the NICU just for a day or two and then move on?
Absolutely. We see those kids that come in, they just need a little puff on the CPAP, little positive pressure to get those lungs popped open, and within a day they're fine. We see kids who come in for just some low blood sugar and nothing else is going on. They just need a little IV just to kind of get them over that hump, get their blood sugar back into a functional level.
And they wouldn't do that just in labor and delivery? Or
to have an IV, we usually like to see them in the NICU. We can check their blood sugars a little more frequently, a little closer monitoring, put them on the heart monitors, oxygen monitors.
Sure. Right. Yeah. They don't. That always surprises me that they don't have all that set up in labor delivery.
They've got the needs. They've got the things that they can do in like an emergent basis. But if we want continuous monitoring, then they really should be under the care of a neonatologist in the ICU.
Gotcha. So as far as IVs go, is it wherever you can get it, or is there a spot where it's more preferred? Do you do scalp IVs mostly? Or?
We're talking when they're this big, their veins are like a pencil line.
That's what I was thinking about that.
Yeah.
Just last night, I was like, sometimes you struggle on like these people with these like, I mean, there's days like everyone knows it. Sometimes you'll have off days with IVs, and so we'll struggle getting in an IV on like these big pipes. When I think about especially when you're talking about the size of your hand, that means the vein is like you can't even see it.
So tiny. So we use the little, red lights to kind of see the veins.
Ultrasound at all, or?
No, but they're little. Their skin is so thin, especially these preemie babies, that it actually helps visualize the veins better. I mean, it takes some finesse. We usually go for the hands and the feet. They're the most visible, and they're not as disruptive to the kid being in a swaddle. Stick a little foot out. We can put them up in the scalp. Those are actually great veins up there, but they tend to freak out the parents. They don't like coming in and seeing a big thing sticking out of their kid's head, so we go there last case scenario.
When kids come in the ER will refer them to whoever has worked in pediatrics before. I've been pretty proud of myself of starting IVs on little kids, but I mean getting them even on little kids that are like 1 or 2 or even 3, sometimes it's challenging.
So you start talking to me about a 1-year-old who's got these chubby little arms, and I don't know that I could do that. I don't know that I could. I have mad respect for pediatric nurses who can do that.
Gotcha.
A newborn baby is a totally different animal, and I can do those, and that's what I'm used to. But
what's the hardest complication to deal with?
That's a hard one.
Like long term?
Yeah, so when you get a premature baby who's born, obviously nobody gets pregnant and expects to have a baby that's 4 months early. But sometimes that happens. And when it happens, there's a lot of times not a lot of warning for these families about, oh, hey, your baby's coming, and it's coming now, and it's coming 4 months early. But that's really hard in itself because you have to wrap your head around, okay, I'm spending the last 4 months of my pregnancy or what would have been in the ICU with this itty bitty baby.
Do the moms stay there?
No, the moms can visit though, and the parents are super involved. A lot of times they visit every day, but it becomes this new kind of weird reality for them of having to visit their baby in the ICU for 4, 5, 6 months before they're able to take it home.
Yeah.
So that can be challenging, and you watch the baby grow. You have to help the parents grow along with them and learn this whole new reality that's theirs. So that's hard. But I think the thing that breaks all of our hearts the most is when you have a perfectly healthy pregnancy, a perfectly normal baby, and something goes wrong during the delivery process, and that baby needs to come to see us. It usually happens so quick, and it's so unexpected.
So you're talking about full term, they give birth, something happens, and they have to come and see you.
Yeah.
What is that usually for? Prolapse core?
Yep. A lot of times the baby will somehow lose oxygen during the birthing process and need to see us because they took a hit, as we'll say, with oxygen. And their brain can sometimes really be affected depending on how long that was for. So those are always the hardest cases because there's no reason to suspect anything was going wrong, and all of a sudden it does. You know, you're left with a very confused, very scared family.
Yeah, absolutely.
And luckily a lot of times it turns out okay, but that can be difficult. At least with some of the other conditions, you have time to maybe prepare. It's those times where you didn't expect anything to happen and it did. Yeah. That can really catch you off guard.
Is it 1-to-1 nursing in the NICU? Is it 1-to-2, or how does that work?
So our normal staffing is 1-to-2 or 1-to-3. Okay. Based on the acuity of the kid. So if you have a couple of kids who are close to going home, they're bottle feeding, maybe they're just on a little bit of oxygen.
Gotcha.
We call them feeders and growers. We're just trying to get them to eat, trying to get them to gain some weight, and we'll get them out of here. Typically you have 3 of those in a night. But when you're talking about a baby who needs respiratory support or isn't able to eat or is size of your hand, then those babies are typically 2-to-1 with 1 nurse for 2 babies. And then in the rare instances when a baby is just needing all of your attention, you'll do a 1-to-1.
So do you manage babies on ventilators, respiratory therapy come in and do that, or is it all you guys?
We have a dedicated staff of NICU respiratory on our unit at all times. Okay. So at any given time, we'll have anywhere from like 2 to 5 respiratory therapists that have a dedicated set of patients, and you work side to side with them all night long on a baby that's on respiratory support. Gotcha. So we've got an amazing team up there, and every baby is a multi-dimensional team effort.
Okay. Say for instance on like telemetry or something like that, you have your set of 5, 6, 7, 8, depending on what state you live in, and you have your patients. You're pretty much independent. That was one of the things that I noticed when I came up from emergency was that, you know, we're used to this kind of swarm mentality. Everyone goes in and everyone kind of tackles something and then everyone sits down. When I was on the floor, so I'd go around and I'd be like, you need me to do anything? You want me to hang a bag or something? And they'd be like, no. Like, don't you got patients of your own? I'm like, I got nothing to do. Like, because it's so helpful for someone to take something off your plate, you know what I mean? And so it's very much independent. It's like a team effort. You have other nurses involved with your baby, or is it more like it's just ancillary staff?
It's absolutely. And babies, they want what they want when they want it. And so you have to work as a team. Because if a baby wakes up and wants to eat, you have to feed that baby. And if you're in the middle of feeding another baby, you just have to. You have to work as a team. You have to delegate to each other, really just call on each other. We usually have a resource nurse on the floor who's also floating around, who can give us an extra hand. When it comes to putting an IV in a baby, you gotta have 2 people. One person is really focused on getting that IV in, and you need someone else to hold and comfort the baby, hold on to its pacifier. You know, it's really a team effort. Everything we do in the NICU is all about coming together.
How do you feed a baby that's the size of your hand?
Well, they don't eat yet. They're usually bigger before we even have to actually feed them.
What do they do?
We have little feeding tubes.
That makes sense.
Yeah. We have, and they're
every
so
time
tiny.
I see a picture, they got the little feeding tube in it.
Yeah, just the tape to their side of their face. But they're these tiny little tubes. They just kind of go down their nose or their mouth, and it just sits in their tummy, and just put a little piece of tape on their cheek, and it holds it in there, and they're good to go. And they do that until they're about 6 weeks from their due date, and then we can start nippling them.
how much math do you think you do? Or they stress the hell out of that, and with good reason. They want you to be able to, like, you know, convert to the milliliters, the teaspoons, the tablespoons, stuff like that, and also just know how to do calculations that are required for pediatric patients. Do you guys bust out the iPhone and like do them on your calculator, or do you have a program that's embedded within, say, Epic or another system, or do you use like Windows Start Calculator and then do it that way, or is it already programmed into the MAR?
Oh, we've got the whole gamut, and you've got so many people who want to do it however they feel comfortable doing it.
Okay.
I am an old school pen and paper kind of girl, so I like to write it all down. And so when I get on shift and I have a baby who's on a drip, I will sit there and draw it all out on my piece of paper, and I'll have that second nurse coming off her shift to validate my math, her math. We're all in agreement, and then we can verify it with the MAR. And the electronic MAR will always show us the medication, show us how it's administered, and it'll go through all the math for us so we can triple check. Because the smallest thing in these little guys makes a huge difference.
Oh, yeah.
Our medication doses are teeny tiny sometimes.
I can't imagine. I mean, medication errors. That has got to be one of the most scary things to do, I think.